Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristen Jackson. Every week, my incredible and knowledgeable nurse practitioner, Rosalind Arp, and I share our combined 30 years experience to guide both men and women as they age. Listen as we dive into a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. These real-life insights are always rooted in solid scientific knowledge. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older. Welcome to today's podcast, where we are tackling the challenging topic of recurrent bladder infections. This is something that plagues women really of all ages, but it does seem to be more common as women get older and are in the postmenopausal timeframe of their life. And we get lots of referrals, either from patients themselves or from primary care physicians who just say, I've treated UTI after UTI. I don't know what to do with you anymore. Please go see a specialist.
So I want to start with what is a UTI. So UTI stands for urinary tract infection. And when we talk about the urinary tract, it can be the kidney, the ureters, the bladder, or the urethra. So you can have an infection in any of those organs. Mostly it's the kidney or the bladder we're talking about. So when patient says, I've had UTIs, and I said, oh, you're a bladder infection, they sometimes don't associate the two together. So what we're talking about today are bladder infections, but also is known as a UTI.
Exactly. So UTI is like the umbrella term, and each of the organs underneath it has their own specific term. So a bladder infection, the medical term for that is a cystitis. A kidney infection, the medical term for that is a pyelonephritis. But they could both be considered urinary tract infections, since both the bladder and the kidney are part of the urinary tract. And if a patient has had a bladder infection before, she very much remembers what those symptoms are. It's burning while you're urinating, urgency to go to the bathroom. Sometimes you have to go very frequently and only a little bit comes out, getting up at night to go to the bathroom, or even new onset urinary leaking are common with a bladder infection. But a bladder infection is not the only answer to those symptoms. In fact, all of those symptoms of burning and urgency and incontinence are common as women age. So it's really important to make sure that we are doing a full evaluation of our patients with those symptoms to make sure that we have a bladder infection before we just throw antibiotics at a patient.
We tend to see patients more in our office for recurrent bladder infections or recurrent UTIs. And that typically means 2 in 6 months or 3 in a year of documented urinary tract infection. There is a difference between recurrent urinary tract infection and persistent. And most of the time, when the patient comes in, we really do not know, because they would just say, I've had infection after infection in the last 3 months or 6 months. Unless their prior provider was collecting urine after they were treated with antibiotics, we don't really know if it's a persistent versus recurrent. So the difference between the two is a recurrent infection is they get an infection today, and then we treat it with antibiotics. Their repeat urine culture after that would be negative after they've finished their treatment. And then a few weeks later, they might get another one, or a few months later, they might get another infection. So it's completely two different bacteria versus persistent infection. It's more so when they have been treated with antibiotic and they never get tested. After they've been treated, we repeat their urine culture, and it shows that the bacteria is still there. Their symptoms might be relieved because there's less inflammation, but more than likely their symptoms will return in a few weeks.
And the numbers on repeat infection are actually higher than you might think. So if a patient has a documented cystitis or bladder infection, the chance that she'll have a second infection in the next few months is as high as 40%. So having one bladder infection and then having a second one right after it is actually a pretty common event. And I think the reason for that is when you have a bladder infection, the lining of the bladder gets all inflamed and irritated and broken down. We take an antibiotic to kill the bacteria that causes that inflammation. But then we expect our body to heal the inflammation in our bladder lining, and that takes a little bit more time. So until the bladder lining has fully healed, we're sort of at risk or open for the next infection. And I think that's why that rate of reinfection ends up being so high.
When patients come to us with recurrent infections, we recommend a full pelvic exam so we can check for any urinary retention or pelvic organ prolapse, which increases the risk of bladder infection. We also want to check if they have any atrophy because that can lead to burning and irritation, and it can lead to symptoms of a UTI in the absence of an infection.
I'm always shocked at how many patients come to see me and maybe they've previously been seeing a urologist and been treated for infection after infection after infection. And I'll say, well, I need to do a pelvic exam. And they're shocked. They say, well, my old doctor never did a pelvic exam. And I think, how can we properly evaluate this patient without examining the bladder, seeing if the bladder empties all the way? Because you can imagine if the bladder does not empty well, that urine sits around in the bladder and gets stale and has a higher rate of being infected. And that can happen with prolapse or without prolapse. And as you mentioned, if the tissue of the lining of the bladder and vagina is just all broken down, there's no protection against infection. So of course, they're more at risk for repeat infections. So sometimes just elevating the prolapse, treating the atrophy with vaginal estrogen, getting the bladder to empty all the way, that's all we need to treat the infections and prevent them from coming back. But you would never know without examining the patient.
And I think with the increase of telemed, which is very convenient for many, has caused more of this phenomenon and patients getting antibiotic after antibiotic through telemed providers as well, where I've had a patient say, I've been treated 6 times in the last 6 months through telemed, and no one has run a urine. And I mean, they're taking antibiotics for possibly not an infection.
Exactly. And I think telemed can be a great option if you are an otherwise healthy patient who is up to date on their GYN exam and you don't have any abnormalities of your urinary tract or your GYN organs. If you have symptoms of a UTI and the easiest way is to call a telemed doc and get a prescription, that may be fine. But if you're not getting better or you're having repeat ongoing symptoms, that's when it really is of value to do an in-person visit that includes a full examination.
When patients come in for recurrent bladder infections, we really want to evaluate the whole urinary tract. We want to evaluate the kidneys, which is the upper urinary tract, and also the bladder, which is the lower urinary tract. We typically evaluate the kidneys by ordering a renal ultrasound or a special CAT scan for the kidneys called the CT urogram. In the bladder, we typically will evaluate it with something called a cystoscopy, where we would look inside the bladder using a camera, and it's done typically in the office. And sometimes we will also order a urine PCR testing to see, to look at the bladder lining.
Right. In the kidney, we're looking for things like kidney stones, kidney tumors or masses, or even backflow of the urine from the bladder up towards the kidneys. That's called hydronephrosis. And we can see that as swelling in the kidney tubes or even in the kidneys themselves. All of those things may put the patient at increased risk for bladder infections. In the bladder itself, when we're looking for either breakdown of the bladder lining, we're looking for stones, tumors, or polyps, other anatomical defects in the bladder. And most importantly, we're looking in the urine to see, is the urine sterile or does it have a low level of ongoing bacteria? And this is actually an area of relatively new study for the bladder. It has historically been believed that the bladder is a sterile place, meaning it harbors no bacteria at any time, which would mean anytime we get a bacteria in the bladder, that's a cystitis and an infection, it needs treatment. Well, what we're learning now with improved testing of the urine is that the bladder is probably not a sterile place. We're supposed to have healthy versions of bacteria that live in the bladder and actually prevent infection for us. And just like the vagina, when those healthy bacteria levels go down, it can allow a whole host of unhealthy bacteria levels to grow up. And that also puts patients at risk for bladder infection.
What does the PCR testing tell us?
So we need to understand how the PCR testing is different than the traditional urine culture. The urine culture is a test that's been around for probably over 50 years. And the test itself is designed to look for the most common pathogens that we find in the bladder. Those are things like E. coli and Enterococcus. So the urine culture picks up the top 3 or 4 organisms that cause a UTI. But in 2023, there are so many more organisms that potentially can cause a bladder infection. And the urine culture just is not designed to pick them all up. Urine PCR testing is done differently. It actually just looks for minute amounts of bacterial DNA that might be present. So it can pick up much lower levels of bacteria, and it can pick up a much wider number of type of bacteria that can live in the bladder, usually over 30 types of organisms that can live in the bladder, where the culture is only looking for about 3 or 4. So PCR testing has been the newest test on the market to help us evaluate recurrent infections. But with every new test, there's good things and there might be some risk. So I am always telling patients, we don't want to just randomly do a urine PCR test on a patient. If I grabbed 100 people off the street and ran urine PCR testings on all of them, I'd probably get about 50 that were positive, maybe more. And then if I asked those patients, do you have frequent urinary tract infections? Patient 1 would say, no. I ask patient 2, do you have infections? No. Patient 3, I definitely do. Patient 4, well, I had one last year. So even though the PCR testing may be positive in a large number of patients, that doesn't automatically mean those patients are going to have recurrent UTIs. I think it really gets down to the interaction between what is in your bladder from a bacterial standpoint and how is your immune system keeping that bacteria at a low healthy level.
So there are 2 types of PCR testing that we do use in the office. One is for treating active infection, and the second one is used to help us figure out what their biofilm is. Can you tell us more about that?
Yes, because the biofilm is also something that's kind of new to medical knowledge now. We realize that when patients have a bladder infection after a bladder infection after a bladder infection, bacteria are smart. They're learning as we try to kill them. So when we use an antibiotic that is meant to kill a certain type of bacteria, it doesn't kill 100% of the bacteria. Maybe it kills 95%, which is enough for our immune system to wipe out the last 5%. But that last 5 surviving percent of bacteria, why didn't they die from the antibiotic? They must have some slightly different genetic makeup that allowed them to resist it. And that sometimes allows the bacteria to almost embed itself in the bladder wall and start to produce a product, which has now been called a biofilm, that covers itself. So try to imagine this low level of bacteria embedded deep within the bladder wall with almost like a layer of slime over it that the immune system cannot penetrate. That's my best description I can give you of the biofilm. Patients who have a pathogenic biofilm might be at risk for future infections because there's always this low level of bacteria deep in the bladder wall that the immune system just cannot get rid of. And there's a lot of research being done on this biofilm and how do we prevent it or treat it, or do we need to prevent and treat it? As I said, some patients may have a positive biofilm and never have a UTI because their immune system just is strong enough to control it. And other patients, maybe they just have a stronger biofilm and their immune system can't get to it.
Yeah, and as a side note, when I went to one of the gynecology conferences like 6 years ago, that was also the biggest topic of discussion for the vaginal biofilm and recurrent like yeast and bacterial infections in the vagina. So it's definitely a new section of medicine.
It's something we're learning about all over the body. I've read articles about the oral biofilm. And does mouthwash disrupt the oral biofilm? So should we not be using mouthwash because we're actually killing the healthy bacteria in our mouth? So I think our knowledge is just simply not complete in these areas. And the testing we have today is just much more advanced than the testing we had 15 years ago. So of course, we're going to learn more as our testing shows us more.
So what are treatment options for recurrent bladder infections that you've recommended?
So we always start with the basics. If your exam shows that your bladder's not emptying well, we want to take steps to make sure your bladder empties completely, whether that's putting in a pessary to lift up your prolapse or using medications to help your bladder empty completely. If the lining of the bladder is thinned because of atrophy and menopause and age, we want to use products like vaginal estrogen to thicken up that tissue and almost make a physical block to the bacteria getting into the bladder. And of course, we want to make sure there are no structural defects both inside the bladder and up in the kidneys that might put you at risk for infection. But if we've corrected all those things, then we want to move on to how do we actually treat it. We do have testing now, as you mentioned before, to see if the patient does harbor a pathologic biofilm bacteria. And if your test for that biofilm bacteria is positive, usually the first line treatment is something called suppression antibiotics. These are a once a day, very low dose antibiotic that you usually take for a course of 3 to 6 months or even more. And you can think of this as every day a low dose antibiotic trying to poke a hole in that biofilm. So after days and weeks and months, we've finally poked enough holes in the biofilm that the immune system can wipe it out.
One of the main questions I hear from patients is like, isn't taking a daily antibiotic bad for you and you can cause resistance?
I get that question a ton as well. And it all comes down to the proper dosing. When we have an active bladder infection, we want to take a treatment dose of antibiotics. That's typically a higher dose taken 2 times a day, sometimes 3 times a day for a short course, 3 days, 5 days, or 7 days. That is meant to treat a high level of active bacteria in the bladder. But when we are suppressing bacteria, we're taking a very low dose once a day only. This suppression dose is not enough to treat an active infection in the bladder. But by keeping the dosing really low, we are preventing that bacteria from becoming resistant to the antibiotic. We're also preventing wiping out good, healthy bacteria. So we tend not to get yeast infections on suppression medication or GI side effects on suppression medication because the dose is kept so low.
So what I typically tell patients is the ideal situation is not to take antibiotics, but currently they're having recurrent infection and taking high doses of antibiotics monthly is probably going to affect them more than taking a daily antibiotic for 6 months. So there is a reason for them to stay on it, and we're not planning on keeping them on that lifelong. It's just to help make those little holes in the biofilm.
Antibiotics are only an addition to what your immune system is already doing, because most people don't realize our immune system is working for us constantly in the background. So there are plenty of patients who get a little bit of bacteria in the bladder, but the immune system is able to wipe it out before it becomes a bladder infection. That probably happens a ton of times that we're just not aware of because we never get a UTI from it. So we don't even know that our immune system was successful. We only know when our immune system failed and we actually get the UTI. And then we think, oh, now we've got burning and urgency and we need a treatment.
I always say that to patients when they're like, when you inhale a lot of things all the time, viruses, bacteria that you don't get sick from. And then, and that's the same way in our bladder.
Exactly. Same way in our GI system. We eat food that has contaminants on it. We don't get food poisoning all the time because our stomach acid kills it. And we have so many immune mechanisms in place to help keep us safe.
So how about for patients who cannot tolerate a suppression antibiotic or wants to avoid that?
So this is something that we have actually done in our practice for many years, and it's actually coming to the forefront as maybe a secondary line of treatment if suppression is not a good option for patients. And it is placing liquid medication directly into the bladder to help sterilize the bladder and heal the bladder lining. They might be called bladder lavages. Lavage is a French word for wash. Some people call them bladder installations. But it's a cocktail of liquid medication that's placed into the bladder with some frequency, once a week, twice a week, depending on what the patient can do, for a series of weeks to sterilize out the bladder in the absence of taking oral antibiotics. There's no one recipe for these bladder lavages. Each urogyne tends to have their own cocktail. They usually, however, are based with a heparin lidocaine base. And then sometimes we'll add in antibiotics. Sometimes we'll add in an anti-inflammatory or a steroid. And the medication is placed into the bladder. We ask the patient to hold it in the bladder for about 30 minutes or more. Then they can urinate it out. But over time, placing a series of those bladder lavages has also been successful at reducing recurrent infections.
And that's because it decreases the inflammation of the bladder lining and helps heal the bladder quicker, so that there's less likely for any bacteria to embed and grow again, right?
Exactly. It's another way we are strengthening the local immune system of the bladder. Because if we were to have a completely intact bladder lining with no pathogens in it, we shouldn't be getting UTIs. So we're just more rapidly trying to get the bladder back to a place where it has its own natural immunity. We've been doing bladder lavages in our office for over a decade, and we have patients who have great success with them. We don't only use them for recurrent bladder infections, we also successfully use them for bladder pain syndromes. Those are things like chronic interstitial cystitis, where patients constantly have bladder pain, urgency, or frequency, but not infections. And bladder lavages can work very successfully in those arenas as well. We've occasionally had patients who've been able to self-administer their bladder lavages at home. It's a little bit challenging because you do have to mix all the ingredients together, place a catheter in the bladder, and then push the medication through the catheter. It's not impossible to do, but it's just much easier for us to have all of the ingredients at the office and mix them as each patient comes in.
The other treatment that I usually hear regarding recurrent bladder infections are all these supplements that are coming to the market. And I get a lot of these new supplement companies coming out with their own cocktail of decreasing their bladder infections. What is your take on that?
So I think it depends on where you are in your treatment scheme. If you are having active bladder infections and you have an inflamed and torn up bladder lining, there probably isn't anything that a supplement is going to do to get you back to normalcy. But if you've gone through a treatment series, whether that's a course of suppression medication or a series of bladder lavages, and now you've restored the health of the bladder, some of these products might be helpful at maintaining the health of the bladder so it's less likely to break down again. So some of them have specifically been looked at. Cranberry is probably the one that popularly most people know. So if you think you have a UTI, people will say, drink a lot of cranberry juice or take a lot of cranberry. And cranberry does have a product in it that prevents bacteria from attaching itself to the bladder wall. The problem is that you have to have the cranberry concentrated in a high enough concentration to do the job. So cranberry drinks generally are not concentrated enough to do that. Not to mention that a lot of cranberry drinks are also really high in sugar because the cranberry is so tart, you have to put sugar in to make it tolerable. So we're actually only adding sugar to the system and not enough cranberry to be of value. But there are some supplement makers that will make concentrated cranberry tablets, and they may have some benefit at the prevention of UTIs once your bladder lining is fully healed.
What is the risk of taking cranberry when you have an infection?
So cranberry itself is an acid. So when your bladder is already inflamed, taking an acid like cranberry may actually increase the inflammation. So when you have an active infection, cranberry probably can't do much for it, and it may actually flare your bladder to cause more pain.
So what I usually tell patients, it's kind of having an open wound, like, or an irritated area of your skin, and you're pouring acid in it. It's not going to feel great. That's an analogy I think a lot of patients understand when taking cranberry can actually make your symptoms worse. It's not going to harm you in a sense, but it can just make the symptoms last longer.
Exactly. And the other product a lot of patients have heard about is something called D-mannose. And D-mannose is actually a sugar. We just can't process it. So it passes through our GI system and comes out in the urine. And D-mannose, again, has been shown to be helpful to prevent the attachment of E. coli bacteria onto the bladder wall. So if you happen to have had a lot of infections from E. coli, and now you've cleared them, maybe D-mannose will be helpful for you preventing E. coli infections in the future. But unfortunately, we see patients with so many other types of infections outside of E. coli that D-mannose has only been proven to be helpful in that one type of bacteria. So again, not harmful, may be helpful against E. coli, which is a common pathogen for UTIs, but it doesn't prevent against all types of UTIs.
Since you mentioned E. coli causes 70 to 75% of urinary tract infections, from what I understand. How do you get other types of bacteria in the bladder?
Certainly, people get very worried when they have E. coli or enterococcus in the bladder, because somewhere along the line, someone will tell them, oh, those are bacteria that live in your stool. So you must have stool contamination of your bladder, and that's how you got them there. And that's probably not true. What's probably happening is that E. coli, Enterococcus, Pseudomonas, Klebsiella, all of these bacteria are becoming more and more prominent in the community. And when I say in the community, I mean in healthy people walking around outside the hospital. We used to see some of those bacteria only when you were hospitalized, where we saw the really nasty bacteria. Now we're seeing them out in the regular community. So probably patients have all of those types of bacteria living on the skin, around their rectum, around their perineum. And if the numbers start to grow, they can invade the bladder, especially if a lot of these immune mechanisms have broken down. So I don't think it's anything that the patient is doing wrong. I think it's a change in the bacteria that live in our world that we are exposed to that put us at increased risk for these unusual types of infections.
Leading to that, I know a lot of them our patients blame themselves regarding their urinary tract infection of like, I wipe myself, I'm clean, I don't know why I keep getting this, and they feel quote unquote dirty. And I always tell them that's not the case.
That is something that we repeatedly do, is to try to remove this guilt from patients that they're causing their own UTIs. In fact, many of the things that doctors even have told women to do for centuries have actually been proven to make no difference in the rate of UTIs. So I'm sure you've heard of these things, but you should only ever wipe from front to back in the bathroom. We teach that to every little girl who learns how to potty train. And they actually have done studies to show it doesn't make a difference whether you're wiping from front to back or from back to front. Now, I still tell patients to wipe from front to back, but I'm just not going to blame them for causing their UTIs if they're just kind of wiping and not thinking much about it. The next big myth that is out there that causes UTIs is not urinating before or immediately after sexual intercourse. So I can't tell you how many women who say to me, I empty my bladder before we have sex. The minute we're done, I run to the bathroom and empty my bladder, and I still got a UTI. That's because those interventions, again, have no bearing on whether or not you get a UTI. I mean, it's certainly good to empty your bladder before sex because it's probably more comfortable to have intercourse without a full bladder, but it doesn't have any value in preventing UTIs. Other things like excessive scrubbing and washing or douching, where you think you're trying to be excessively clean, what you're probably doing there is washing out all your normal healthy bacteria that provide you immunity against these infections. So those things you're actually probably doing more harm than good.
I've heard of patients tell their partners to make sure they take a shower before they have sex, and like they both have to be showered completely, and like it just removes the spontaneity. So it's like it's not going to prevent you from having a urinary tract infection. It's okay. Like I have to excessively repeat that to patients sometimes.
Exactly. Or it makes their partner feel horrible if they shower and then have sex and the patient still gets a UTI. They feel like, oh, I did that to her. Did I not clean well enough? It has nothing to do with that. So if you want to shower before sex, just so you're both clean, that's a great idea. But don't worry if you want to have sex and nobody has showered. That's perfectly fine. That is not the cause of the urinary tract infection.
I've also heard from patients that they will go to the bathroom more often because they're afraid they're going to get a urinary tract infection. Has that shown any in the study to prevent urinary tract infection?
Not as long as your bladder empties successfully in the first place. So just increasing your frequency of voiding or urinating on its own doesn't seem to make any difference at the rate of UTIs.
So why is sex such a trigger for urinary tract infection typically?
It makes sense that when you are having vaginal penetration, the penis is rubbing along the base of the bladder. So if you already have a slightly inflamed bladder or a bladder lining that's a little bit broken down, or one of those pathogenic bacteria that's created a biofilm in your bladder, and then you have friction on the base of the bladder and you stir all of that up, it's going to increase your bladder symptoms after an active intercourse. So it may not necessarily be stirring up an actual infection. It may be increasing the inflammation you have in your bladder. But many women do feel like the active intercourse irritates their bladder with those UTI-like symptoms.
So do you typically recommend for patients to wait and see if their symptoms get better rather than treating for an infection right away after intercourse?
I think it depends on what their diagnosis is so far. I think when patients have an embedded bacteria creating that biofilm, once we've started them on a suppression medication, after about a month, they may feel that the active intercourse no longer stimulates those bladder symptoms. Or if we're going to have a patient who chooses to treat with bladder lavages, after 3, 4, 5 bladder lavages, because we've healed that inflammation somewhat, they now feel that the stress or trauma that they get on the bladder during intercourse no longer flares their bladder symptoms. But I don't tell patients necessarily to stop. It's not harmful to be having sex during these timeframes. It just may increase the number of symptoms that you report.
I have recommended for patients as well, like to drink lots of fluids before and after, just because not necessarily after intercourse right away, but more so like it decreases your inflammation when your bladder is not as concentrated with urine.
I agree with that, definitely. I tell patients just to keep an eye on the color of their urine. So usually when we first wake up in the morning, the urine is very concentrated. So it might be golden or amber in color. But as we start to hydrate through the day, the urine should become very light yellow or clear. And that very dilute urine is probably much more comfortable to hold in an inflamed bladder as compared to very concentrated urine. It goes back to that same analogy of pouring acid on a cut. If you have concentrated urine and a broken down bladder lining, that's going to feel really irritated versus if you just have watery urine on that, it doesn't feel so bad.
And a lot of patients says it's so counterintuitive because they're like, I feel like I gotta go all the time. And I tell them, I'm like, well, to treat that is to drink more water. And they're like, but that's so counterintuitive. And I'm like, I understand. But when you explain it that way, they do understand that part. Yeah.
Right. And there are the over-the-counter products like Azo, that's spelled AZO. Those are really just like a Tylenol for the bladder. When you take it, it temporarily coats the bladder lining and calms that inflammation down. So Azo is great for giving you some immediate relief from the bladder symptoms, but you don't want to take Azo long term. It's not something you want to be taking day after day and month after month. You want to get to the root cause of it and just use Azo here and there when you get a little flare of your bladder pain.
I usually recommend that for patients who have irritation after intercourse, if they feel like they need to take something, and that helps prevent that burning sensation after sex the next day. What about the after sex antibiotics? I know that was an old treatment that we used to do. Is that something still recommended?
Some people do still use postcoital or after sex antibiotics, but again, it's all about the dosing and the frequency. So the proper use of an antibiotic after sex is to take 1 tablet, low dose, as a prevention for UTIs. And for many women, especially many young, healthy women who have no other abnormalities of their urinary tract, that can be a successful method. But what I hear from patients is that they'll take one, and then later that day, they'll take a second, and then the next day, they'll take a little more because they just want to make sure they don't get one. Well, now they're moving out of the realm of suppression and into the realm of treatment. And when we increase that dosage like that, that's where we get into complications like bacterial resistance and yeast infections.
And one thing I wanted to add earlier regarding suppression medication was when patients are on suppression medication, I also tell them that it doesn't mean they're not going to get any more urinary tract infection. It just means it decreases their risk of getting urinary tract infection. So there is always still a possibility that they can get a UTI while on suppression medication.
That's right. And when you complete suppression medication, you may have had a great 6-month course of no UTIs and you're feeling wonderful. So you go off suppression. That doesn't mean that never again in your lifetime will you get a UTI, because a new situation may develop 1, 2, or 3 years down the road. A new bacterial biofilm may have been created. So it's something that for some patients, we do a course of suppression, and then maybe a few years later, we have to reevaluate, retest, and do a second course of suppression. It's just ideally not something we want to put them on and keep them on for the remainder of their life. Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.